So this is a 21-year-old badminton player with an ACL tear case.
Don't worry. So what we're looking at is a 21-year-old lady who she likes to play badminton and she plays at club level. It's all very important to know that all ACL deficient knees are not the same. Some may have varus, some have high slope, some have hyperextension, and our treatment plan needs to vary when we are trying to deal with all of them. So what do we have here? We're going to discuss this lady with a BMI of 24. She fell while playing badminton about 5 weeks ago. She's not able to walk on the injured lower limb. She saw her primary care physician. She's been put on physical therapy and bracing. She's not getting better, so obviously she needs surgery. What does she have? She has hyperextension of 10 degrees. The opposite side has a 20-degree hyperextension. And of course, she's got a torn ACL. This is not her image, but this is just a representative image. She's got a torn ACL, and she has a repairable meniscus tear with stable collaterals and neutral alignment. So, we're going to have a debate where we discuss graft choices, and Sarthak and Rajiv will introduce the speakers who will debate for a particular graft choice.
Yeah, good evening. So my first speaker is, I would like to invite Dr. Shomidip Datta to give his talk on hamstring ACL reconstruction plus sleep.
So thank you, Chairperson. So this is my situation. I have been caught between the two strong graft. So I will put my point here. So what is the purpose of the ACL in this patient? So she wants an absence of pain, swelling, instability, restoration of the full range of motion, muscle strength, restoration of her proprioception. She obviously wants to return to badminton and restoration of the normal knee kinematics and prevention of further osteoarthritis. So this is a Swedish registry data which is clearly showed in specifically in the badminton player, the only ACL reconstruction, the return to sports in the same level is only 19%. That means 4 out of 5 patients will not able to go to return to the sports by doing the ACL alone. So next come, why hamstrings? There are different papers. I'll just quote this journal from the knee journal. It has a very low post-op complication compared to BTB, like anterior knee pain, patellar fracture, and tendon rupture. Especially she is a female, so Indian female will expect a very short BTB, and chances of fracturing patella is very high. Less post-op stiffness and loss of extension, because in BTB graft there is a high chance of loss of extension, which is very important for a player like her. It's a small incision, better cosmesis, and prevention of the extension mechanism, which is very important for jumping, which is integral part of her sports. There is a concept that the bigger graft is the stronger, but actually it's not. There is a meta-analysis study which has shown, and that is also a paper in the AOS journal that has also shown that hamstring quadruple is equivalent to tensile load and stiffness in there. So there is a 2013 Moon cohort study. It has been described that hamstring graft more than 8 has a very low chance of failure. So it's a very strong graft. Chances of failure is very less. So why LET? Because anatomical ACL reconstruction is an oblique graft that exposes to high rotational force for this patient. LET controls the anterolateral rotational instability, longer lever arms, more resist to the torque. It just acts as a seat belt to protect the graft. That has been described in different papers. This paper and this paper also, this has shown that adding LET reduces the forces on the ACL by 43%. There is a bad thing has been told that doing an LET will increase the chance of lateral osteoarthritis. There is a 20-year follow-up in this paper that has shown that the LET doesn't increases the chance of lateral osteoarthritis. So any procedural Lamar or Ellison is done. So for this patient, I will straightforward go there. I'll not go to the video for the sake of time. I'll do a standard ACL reconstruction. And this is my tunnel. Tunnel position is absolutely important. This is my graft. And then I will do a lateral extraarticular tenodesis. I will take a long 7 centimeter graft. I will take the graft and put the graft over just under, pass under the lateral collateral ligament and get a very strong knee for this patient. So I'll also quote this multicentric RCT published in the ISACOS journal. That is 300 patient has been examined on both the groups. So adding an LET has significantly reduced the chances of failure, especially in young, active and high risk patient, and improves the rotational stability. So in a nutshell, hamstring offer a very biological but very strong graft, LET needed for a high grade FreeBot 2 and 3 like this patient, an athlete, and takes control of the rotational instability. Thank you for your kind attention.
Thank you, Somadip. Please come here. So our next speaker is Dr. Vikram. He will be talking on hamstring ACL with internal brace oblique synthetic graft.
Thank you, team Ski. And what graft to use opens a Pandora's box always. So I want to just tell you what my approach to this kind of a player would be. So sorry, I got the sex wrong. It's a 21-year-old badminton player, 10-degree hyperextension, complete ACL tear with a meniscus tear. We need to understand what does this translate into. It's a high-demand patient, high stakes, risk to healing and biology in such a patient because of the hyperextension. And there's disability in this patient. So I believe in this three-wheeler concept. I want fewer question marks on my healing. I want a stable knee. And I want an insurance plan for my stability at the end of the operation. So my approach is a standalone synthetic graft plus a meniscus repair. And these are my reasons. So I don't flirt until I've done a background check. And this I tell you based on my experience too. Having done over 150 in the last year or so, and my results I feel till now have been very, very, very promising. I believe personally that the natural ACL is the best. Grafts may help. But remember, the graft you're putting in is foreign to the knee. You're taking a tendon and replacing it with a ligament, whatever you may call, that's not supposed to be there. So, when a graft is taken out, obviously that we may just satisfy ourselves, our patients are doing great, but that particular part has a function in the body. And once you remove it, the role is lost. And literature supported us, but we like to turn a blind eye onto things which are difficult to answer. And what are the implications? Hamstring autografts have been shown to have lack of hamstring strength, persistent knee flexion and rotation deficits, and altered dynamic stability with increased re-injury risks. Same with patellar tendon autografts, we can't discount anterior knee pain, and so with the quadriceps tendon autograft. So, return to pre-injury sports in badminton is 50.4%. Are you satisfied with your results? And this is Stan's result from Southeast Asia when badminton is played and over 5 to 8 years follow-up. So 50.4 according to me is abysmal. So why use this jewel or a synthetic graft? Murray very nicely put up in his paper 5 years ago that the autograft stretches out over a period of time. So maybe we can make something in a lab that stretches out less and all these factors like slope, etc. doesn't influence it as much. So for me, preserving the native ACL has stemmed from my research on doing primary ACL repairs, and it is very important for proprioception and we can't discount it. So I repair whatever stump is left. It's only 5 weeks since the injury. So you can see here, similar kind of case. If I have a good stump, I repair it back and then pass a synthetic graft as a augment along with my repair in there. Remember, this is made in the lab, and Saumyadeep very rightly put it. It's the bigger the size doesn't mean it's better. So they're able to create something strong enough with smaller tunnels. And we know there are no body reactions. So one thing I can say for certain, in the last year and a half, I've had no body reactions, no synovitis, no aspirations in my patient. So the problem with today's ACL reconstructions, 10 to 20% failure rate, graft harvest morbidity, slower biological healing, and a late return to sport. And my references are below. In the past, we may say they failed. Why did they fail? They failed because of problems in mechanical strength of the graft, older materials that were used, and these were load-bearing grafts. We've moved on from there into load-sharing grafts as of now. So the rise of modern synthetics is based on this, load-sharing from load-bearing. And Trieb and Mascarenhas have very rightly put in their papers. And this proves it. So you can see there's growth of tissue. There have been explanted jewels in which they've done dissections, and they've shown that there has been tissue ingrowth into these synthetic grafts. So the jewel is a braided polyester core with a load to failure ratio of 4,000 newtons. It's hydrophilic, that allows tissue growth into it, and it mimics the native ACL's stiffness and orientation. And this recent study in the knee seems to prove it. Same PROMs at 24 months, faster return to sport, and no graft site complications by Kentel and colleagues. So thank you. I'm going to go with the synthetic ligament in this case. I've always felt torn about using an autograft, but not anymore. Thank you.
Thank you, Vikram. Please join here. So last part of the debate, BTB for ACL by Dr.
Thank
Sandeep
you,
Piraris.
Parag sir, Sachin sir, for this warm invitation. So quickly, I'm going to go through the bone patellar tendon bone graft, and there is a tough debate with Somadeep and Vikram across me. So we have seen the patient, grade 2 Latchman, grade 2 pivot, and hypertension extension of 10 degrees. So we all know that's how the ideal graft should be, and the BTB is the one which checks all the boxes, so I'm not going to go detail into this. So BTB has got a good tensile load and stiffness. And what I see is that BTB is not a graft, but it is a ligament, because it is already stretched to its limit. It is adjusted with the knee range of motion. It is being used most commonly. It has got longest track record. We can get from size 8 to size 12 very well. And it is always considered as a gold standard. So this particular article states that there are certain advantages of BTB. There is a graft laxity which is seen in hamstrings. It can be there in BTB if there is a tunnel misplacement. Tunnel widening is a concern with soft tissue grafts and also with the synthetic grafts as well. And this can be indication for revision surgeries. BTB helps in healing at the aperture, and more than 90% use, I mean almost in 2000s, it was a maximum use of the graft use was the BTB. There are certain disadvantages, which I'm going to call as a perceived disadvantages, like fracture patella baha, it can be surgery related. Quadriceps function can be due to rehab. Kneeling pain is most accepted drawback, and it can resolve within 2 years. Anterior knee pain can be due to some nerve damage. Cosmesis is because of the scar, and many of these also go with hamstring as well. When you look at the athlete, so it has shown that BTB allows better bone incorporation of the graft. Then there are long-term results in meta-analysis. They have seen low graft failure rates, faster incorporation due to bone healing, and greater return to sports. Return to sports, when you think about this, this particular study very clearly states that patient can return to sports by 6 months. It is a KSS study from our own Indian authors. When you think about the hyperlaxity, so this particular study of JSM has stated that BTB is a good if the patient has got more than 5 to 10 degrees of hyperextension, and similar by this study of 2016. So why I choose BTB? Longest track record, it's an ligament, bone-to-bone healing, excellent tensile strength, increased roll load to failure, and I always preferred in hyperlax patient. You can see that's the BTB graft. It looks like as if it's a normal ACL. Thank you very much.
Thank you, Dr. Sandeep.
So I think it's a long debate. Soft tissue graft, bone patella, and now we have synthetic in between. So I would like to ask Somadeep. So you told about the LEAP study. I think this patient, for any soft tissue graft, you want to add the LET? For any soft tissue graft? For any soft tissue
For any soft tissue graft, especially in a pivot 2, pivot 3, high demand athlete, you have to add a LET.
So I think, sir, Sachin sir, you were part of this LEAP study. So we were also, when this study came up, because we were using LET for a revision, as a protection for revision. So nowadays, non-athletic population, soft tissue graft, whether you will use with LET or without LET.
So I think, Rajiv, I'll ask you to hold on for another 10 minutes. We have the next debate on LET, which is going to happen. And let's trash this out after that next debate is sorted out, if you don't mind.
So I have a question to Dr. Soumyadeep. Now this is an hyperextended knee patient. Like, what is your tunnel positioning? And does your graft diameter differs? Like, do you really consider, you think about the graft, especially in a case of hyperextension knee? Tunnel positioning and graft diameter.
Standard tunnel position will not change, but the graft diameter, I will happy anything more than 8. I will accept. For a female, Indian female, I will not. If needed, I will take the gracilis along with it.
So Dr. Vikram, like, since you have talked about synthetic, then you know the jewel, like the graft diameter is always 6, I believe, what we get. Do you think that's enough for any patient with all your patients?
So these are tailor-made grafts in a laboratory. They are tested to check their tensile strength. That's the biggest advantage I feel, because if it's 6 millimeters, it's bone preserving, which improves pain perception post-operatively. Even if by chance you have a revision later on, your tunnels are much smaller, and it's been proven by literature. So they're able to create a graft that's strong enough with a relatively smaller diameter. So it doesn't come into the picture at all here. I think graft diameter is a debated upon topic. It's more for autografts. And even there, I have my reservations about a lot of the diameters that we tend to advocate, because we are people of different races. Our body types are different, our knot sizes are different. So can we have a shoe that fits all is the $1 million question.
So what's the youngest age group you have used synthetic?
So this is not advocated in pediatric age groups. So anyone over the age of 18 years, I'd use it.
Okay, and now we know the BioBrace is there. Like, how do you rate BioBrace with jewel and the internal bracing, what we see in the thing? You know, these 3 things which we use.
So according to me, these are 3 completely independent options. The BioBrace enhances healing, meaning it's always used along with a autograft that you use along. It has type 1 collagen and it helps in integration. Well, still literature is a little less on it, but time will tell. Good idea, but the prices are prohibitive. Of course, the jewel is a standalone. It's a replacement, so it has the advantages. Again, however, mid-term studies only. There are no long-term studies yet. Vis-a-vis the internal brace, again, it's a completely different concept. It is a concept of protecting your graft like a seat belt to prevent it from rupturing. So I think in the early stages of ligamentization, so I think they're completely, they're 3 different concepts altogether. I think it depends on what you believe in and what you use.
Dr. Vikram, I have a question. When we choose graft, finances and costs is something which we have to consider. So if you can't do a jewel, what will be your graft of choice?
Yeah, so very rightly put. I think I'd do a hamstring. I'd do an all-inside ACL using a semi-T. I would add an LET, as Soumyadeep said, if I use an autograft, soft graft, basically to protect my graft and no other reason.
Thank you.
Just adding to that question, Vikram, you said that the tunnel diameter is less if you use jewel graft, and in case of failure, you have the bone could stop intact. So what will you do if it fails?
Luckily, it's too early for me to say. I haven't had it, but I think it would be very, very simple to do a second stage. Depends on figure out why it has failed. More often than not, I think it's surgical factors at the end of the day.
Would you repeat it with the jewel again, or would you do something else if it fails?
So, I don't think I'd use a jewel again, because the diameter is already 6 mm, and I think while trying to, kind of freshen it up,
So
I'd
I'm
need
asking
bigger.
on behalf of these two, that if in case of failure, you will not use the jewel again.
In a jewel revision, I would not use a jewel again.
That's right.
In a normal revision, I could use a jewel along with it.
Yeah, so then why not use the primary graft autograft graft in the first stage?
Why should I? Look at the morbidity. I've shown you what you and me also know. Whatever graft we are using from the body, autograft, it has its own implications.
Do you think 20 or 30 years of ACL practice, we have such a bad morbidity after autogenous grafts?
No. Then if your mobility was not so good, why only 50% of your patients in the best of hands are going and playing badminton?
Another question.
Okay.
Last question from Sujit.
Put more oil into the same fire.
Yes.
Why are we not discussing allografts, which have longer term studies? Jewel
Yes.
is just 2.5 years old.
But I think allografts
And it's
are,
totally
literature
synthetic.
proves that they're inferior already. So I think maybe the jewel will be proven inferior over a period of time, but time will tell right now. But allografts, already I think it's a closed chapter that intra-articularly their success rates are relatively less.
That jewel might be perfect fit for the future. But at present, your hands, the results are 1.5 years.
Yes.
Right? But our
I think
results are
still
20
we don't
years.
have- Still don't have. We
So,
don't
so,
have-
so, so, the other two wins for me.
Yes, yes.
So I
Still
have
we
a
don't
job
have
to
long
do.
Can we
term
have some comment from the right side, sir? Like Dr. Sachin, sir, do you like to add something?
No comments.
No comment. So I think we will have rebuttal. 30 seconds. This. All three. All of them. Sandeep wants to do rebuttal. So he
Sandeep has
prepared some
really
special
prepared it
slide
well.
for Vikram and Somadeep.
Ladies and gentlemen, please have it.
Yeah, sorry.
So PTB.
We have heard the pearls of wisdom from both Swami Soumyadip and Swami Vikram. So I'm going to play video.
Follow-up, of
what
course,
about you?
quadruple hamstring has a long follow-up. BTB has the longest. It was the oldest graft which is used. Unfortunately, we like to reinvent the wheel, so we find new graft sources, but it's a very reliable source.
No.
What are the complications? Quadruple hamstring is infrapatellar branch of your saphenous nerve can get cut. You can get slightly higher infection rates in statistics, less predictable graft incorporation. BPTB, biggest issue was anterior knee pain, chances of patellar fracture. The scar is bigger and patient doesn't perceive it as an arthroscopic surgery. What are the complications?
Oh, sorry.
Graft diameter, we were just talking about it. Quadruple hamstring is unpredictable. Why? Because you may have a different diameter you're born with. I've done some studies on this, MRI, etc., but they're not very reliable at the end of the day.
This is
The
epic.
BPTB is reliable because you're only taking a part of the BPTB. And we all have a particular diameter of the BPTB at least. So if you're going to take, let's say, 7 or 8 mm of that BPTB, we know we're going to get that much. So it's predictable. Graft diameter,
The producers of OrthoTV, beware, we are going to have a lawsuit
These are my
on
graft
you.
choices. When do I use quad tendon? I use them.
Look
when
at his
do I
graft
use
choices.
the all-inside semi-T with internal bracing?
No
When
jewel.
do I use the jewel, which is the artificial ligament? When do I add an LET? When do I do a peroneus longus?
Bias against BTB. So that's why I still choose BTB. Thank you. So you are always welcome to have feelings so long as they don't result in an opinion.
Thank you, everyone. Thank you.
Now we should give Vikram also to speak something.
Vikram, OrthoTV is responsible for this.
I'd request the moderators to please be on stage for the next 2 talks on the LEAP, current recommendations from the LEAP consensus, and a rebuttal to that.
Good evening. It's an honor to stand here. Thank you, Dr. Sachin, Dr. Rajgopal, Dr. Parag for having me here. It's a good mix of arthroplasty and joint preservation. More of a debate, LEAP. What is LEAP? Lateral extraarticular procedures. That is either using the IT band or ALL reconstruction. When the ACL tears, it's a twisting injury or a pivoting which happens, which tears the structures in the lateral side as well. So when the lateral side is unstable, the ACL graft can fail and the knee can pivot again, especially in a high-end athlete. So the pivoting causes a rotary instability. And that led us to the anatomy and function of the anterolateral ligament. That's a high-grade pivoting of the knee joint when you have to think about the ACL, which is a central structure which cannot restrict the axial rotation. So ALL is the answer to control axial rotation more. That's the anterolateral ligament, which comes from the lateral epicondyle to the area between the Jerde and the fibula head. And it has the power to restrict the rotation by 6 times than what the ACL can do independently. So these are the consensus which came out of the lateral extraarticular procedures consensus meetings, or the consensus which happened online from surgeons from 17 countries, 5 continents. Our own Indian surgeons were there in that, with 3 rounded modified Delphi process. 75% was agree and strongly agree. There was a consensus in 2024 which had different the mottos and things which came out of it. And it was further modified in 2025 in September, where 16 statements were finally assessed. So leaps are associated with decreased graft rupture and reoperation rate and improved graft survival. That's one thing which came out strongly. And the key recommendations were the IT band procedures. The graft strip should pass beneath LCL. It should be an anatomical technique is mandatory for ALL reconstruction, and no single leap is clinically superior to other because it's still evolving. And indications are young active individuals undergoing hamstring autograft ACL with a high-grade rotational anterior laxity, hyperextension, and revision surgeries. Maybe high BMI as well. But these were the 4 things which came out very strongly. And modern leaps do not increase the lateral compartment osteoarthritis, which was again something which was strongly opposing leaps when they started, and it does not necessitate changes in the rehabilitation or return to play timelines. When IT band graft is used, it should be fixed in 0 to 60 degree of knee flexion under low tension, routed deep to the LCL. For ALL reconstruction, femoral fixation should be in full extension at posterior proximal point related to the lateral epicondyl. The fixation point is the same. So for future research, they've kept for special scenarios like female athletes. We missed the talk now, probably we'll have it tomorrow, or we can see it online. And impact of a smaller graft size and role of concomitant meniscal procedures. So what is the impact that ALL causes? The diagnosis is with an MRI, you can see the anterolateral ligament, especially when you see a secant fracture. You have to think about the anterolateral ligament which is ruptured. This was a 29-year-old male. I'll just show a couple of case scenarios who had ACL reconstruction done 3 years earlier. His knee was stable for almost 18 months, and then again he slipped and he twisted with no major fall, but the knee was buckling again and he was symptomatic. And that was the X-ray. I could see the endobutton lying somewhere in the soft tissue in the lateral view. AP view, it was missing because it was hidden by the marker on the X-ray. Those are the MRI images. The slope was okay, and no significant fall. He had a hyperlax joints. And ligament laxity was one of the reasons where you have to think about failures which can be probably addressed more by giving extra support than just the ACL reconstruction. He had a meniscus which was torn, and the medial compartment was not arthritic. ACL reconstruction was done, and I use a cordyceps graft as Dr. Sandeep was showing there. I love the cordyceps because you don't have to violate another joint. And the fixation was done with, I use a transverse incision to pull the cordyceps graft in, and the LET done with the IT band. I love the modified lemur. And the fixation is done passing the graft under the lateral collateral ligament. It's interesting to look at the ISOCOS criteria for lateral extraarticular tenosis procedures, which came out in 2023. Due to lack of clear indications, major and minor criteria were described there. So major criteria were 2 points and minor criteria had 1 point. And ACL revision had 5 points automatically. So major were grade 3 pivot, contact sports, high level or elite athletes, or less than 25 years. And minor were generalized laxity, KT1000 difference of 8 millimeter more from the opposite side, chronic instability, medial meniscectomy or lateral meniscus root tear, which we had discussions in the morning today, contralateral instability, BMI of 30 and more, secant fracture, posterior slope more than 10, and severe anterior translations. So more than 10 was an absolute indication to go for an LET there for the ISOCOS group, and 8 to 9 was surgeon's decision based on other factors. So technical factors for the repair, various surgical procedures for lateral extraarticular tenodesis have been devised from 1967 when Lemire described this initially for ACL division knees without reconstructing the ACL. And the main concept of ALL was using either the IT band or a BTB or semi-T or gracilis to build up that lateral law structure on that lateral side. That was a Lemaire procedure. A strip of IT band was taken and passed under the lateral collateral ligament. The knee flexed at 60 degrees and held in external rotation, and the fixation is done. The external rotation was what probably was increasing the lateral pressure, and now it's recommended to keep it at neutral or minimum external rotation. That is a McIntosh procedure, 1976. Strip of IT band again passed through a periosteal tunnel, and the lateral intermuscular septum looped onto itself and stitched onto itself at 90 degree and held in external rotation. That Lossy procedure, 1978. Strip of IT band was detached and then passed through a subperiosteal tunnel and held in 30 degree and external rotation and fixed. There's Zarin and Roy technique again, along with the ACL, passed through the tunnels, and that's the anterolateral ligament reconstruction, where two separate fixation points were used, or three, like in this case, where the fixation was done in the femur and the tibia to prevent the lateral rotations. So take home, so if you're doing ACLs, consider leaps in special scenarios. Peripherally located ACL is the main contributor for rotational and axial stability in comparison to the central located PL bundle. The LET contributes significantly to rotary stability of the knee joint, and lateral extraarticular procedures have to be thought strongly in grade 3 pivots, high demand sports activities, Segan's or generalized laxity, ACL revision surgeries. So LEAP Consensus 2025 gave more guidelines in identifying patients, laying out safer LET procedure guidelines, and the steps from 2024-25 were don't just pick the patients, but optimize techniques. Like the graph routing was described better, fixations, anatomical landmarks were described, and safety statements, no added OA risk if you are careful with your technique. Thank you.
Thank you, Dr. Sujit. So now I would like to invite Dr. Raju Easwaran, who will telling, look before you lean toward leap.
Good evening, thank you very much. And this talk is appropriately titled, whenever we have a new procedure, there is a slight tendency to confirm with herd mentality, and the two consensus statements, the LEAP consensus published in the September 2025 issue of the Arthroscopy Journal, make for an interesting reading. Like the first point, in all active patients less than 25 years of age, the panel unanimously recommended adding a lateral extraarticular procedure, regardless of the graph that you want to use. So that's something which is very interesting. Now, a procedure like LEAP should be first I'd just like to point out some limitations that this paper pointed out, and it is useful to keep in mind that more than 2/3 of the panel reported conflict of interest, but let's keep that aside. What percentage of my primary ACLs are actually failing? And in the absence of published data from India, we have to rely on established registries, and this is a recent paper from the Norwegian registry, which looked at 33,000 patients, and it has a 15-year follow-up. And if you look at the revision rates, they're just 2% at 2 years, 4% at 5 years, etc. And they match with previous published figures. It's a 15-year follow-up, so this is the longest data that we have. And interestingly, there is no mention of LEAP anywhere in this paper. Whereas the scope is from 2004 to 2023, they did report that there was a slight increase in revisions when the clinic switched from a transtibial technique to a medial portal technique. Retrauma obviously remains the most important cause, and when it comes to retrauma, they found that hamstrings graft have a much higher odds ratio of having retrauma compared to the other grafts. So that's the ground reality. I mean, it's not a problem which is let's say, as prevalent as we think it is to add a non-anatomic procedure to our ACL reconstruction. Now, what about the hyperlax? Again, registry data comes to our rescue. This is September 2025, published in the Arthroscopy Journal. And they found that hamstring grafts have a 4-time higher rate of re-rupture in the hyperlax patient. I'll just zoom on to the relevant portion of this table, and you can look at the number of re-tears in the BTB graft, and that's 0. So if you have a patient who is hyperlax, why not switch to a better graft than a hamstring graft, which is an inherently weak graft? and probably needs the support of a lateral extraarticular procedure. The LEAP consensus also recommended that if you see a deep notch on the X-ray, you must go and rush and add a LEAP procedure to it. Thankfully, common sense prevailed. This article is published, and our own Vikram has given an editorial commentary on it. The lateral femoral notch sign is just an indicator of a high-grade pivot. It does not mean that your graft is going to fail more. Now, the part 2, which techniques were used to do the lateral extraarticular tenodesis. So, modified Lemire was the most popular technique amongst surgeons. And regarding complications, a simple line was mentioned that there are complications with LEAP, but the incidence is low. We don't know how low is low. But let's look at all the lateral extraarticular procedures and let's try to understand. Let's all at least agree that LET is a non-anatomic procedure. It can only work if it adds constraint to the lateral side of the knee. And there are 3 categories, procedures which cause severe distortion of existing anatomy and create new anatomy. There are procedures which cause moderate distortion of existing anatomy, and then there are procedures which cause minimal distortion of existing anatomy. But the common denominator is a strip of IT band is passed deep to the FCL, and as you go up the non-anatomy ladder, the constraint increases, and therefore the protection of the graft also increases. So ALL reconstruction and the most popular technique, modified Lemire, they distort anatomy. They create new anatomy. You put the ligament, this is an imaginary ligament, you have created an imaginary isometric point, which very frequently collides with the ACL tunnel as well. So intraoperatively what you do, you just put it where exactly you want to put it, where the tunnel doesn't come. Moderate distortion of existing anatomy is this Arnold-Coker modification, and this has good long-term published data. The Italians have been using it for quite some time, and this is 18 years published data of the Arnold-Coker modification. And the modified Ellison is the one which has the least distortion of the existing anatomy. You just detach it, and then you reattach it back by passing beneath the FCL. Complications are emerging. This is an ahead of print article published, and as we see these procedures being adopted sometimes without any valid reason, we will see more and more complications. Simply because just like a financial investment can compound, if you do a non-anatomic procedure on a 16-year-old or a 17-year-old, by the time he's 40, 50, you will discover something which you didn't anticipate when you started to do this procedure. So I'll quote Donald Rumsfeld, the absence of evidence is not necessarily the evidence of absence, and we'll meet one of his quotes later. So Carl Raymond Popper is a very interesting philosopher. I mean, this null hypothesis, etc., is all creation of Karl Popper, and his greatest contribution is the clocks and clouds concept. Now, whenever we look at a complex problem like an ACL reconstruction or a rotator cuff repair or anything which doesn't have clear answer, we like to think that it is methodical. It's like a clock. It has one dimension, and therefore if we increase the constraint on the lateral side, things will work better for us. But in reality, complex problems are like clouds. They have dimensions that you probably don't even know as yet. I'll just give 2 simple examples published in the literature. One of them is arthrogenic muscle inhibition, again published by the biggest proponents of ALL and LEAP procedures, Bertrand-Henri Cote. We all have seen irrecoverable quadriceps atrophy after our ACL reconstruction. Something happens at the cerebral level, we don't have a good answer, but then if these patients go and return to sport with a weak quadriceps, they will have increased re-rupture. There's another concept which is gaining a lot of traction, something called cognitive motor interference. Now, why are these athletes not able to play and get back to sport? Because sporting environment is a complex environment. It's not a lab where you can do a test in one dimension. Your brain has to choose between a cognitive and a motor task. And these studies have shown that the ACL injured brain does not know how to switch rapidly between cognitive and motor tasks. And a lot of new rehab modalities are coming. So these are 2 new facets which we are seeing, which may account for increased ACL ruptures. So I'll again quote Donald Rumsfeld when he was asked about weapons of mass destruction. He was the US Secretary of State. And he says that there are known nodes. We know that ACL tears causes instability, and we know that if we do a good reconstruction, we can take care of that. there are known unknowns. We don't yet know why the graft fails. We think that something on the lateral side exists, some imaginary ligament exists, and if we reconstruct that or repair that, probably that will give us an answer, but that will come at the cost of unknown complications as well. But there are also unknown unknowns, things like cognitive motor interference, which most of us probably have not even thought of. So this is the area where the research is headed. Perhaps re-trauma is something you really can't prevent by doing a lateral extraarticular procedure. If the patient has a trauma of a sufficient intensity, he or she is likely to fail. So I would advise the Aesop's Fables classical line, please look before you leap. There's a lot we don't know, and simply doing a non-anatomic procedure on the lateral side may not be the best answer. And if I can quote Shashi Tharoor here, he was once asked by a journalist as to what he thought India was. Do you think India is a developing country or an underdeveloped country? And he gave a very nice answer. He says India is an overdeveloped country in an advanced stage of decay. So ACL surgery is an overdeveloped surgery, and we are slowly seeing signs of decay when we have to resort to non-anatomic procedures to protect an anatomic reconstruction. Thank you.
Yeah, so 1 minute I think rebuttal, then we will have discussion. Yes.
So about what Dr. Raju said, my thought was also the same in maybe 5 years or 8 years earlier when I was introduced to the LED technique, and for primaries my threshold is very high to do an LED. But then for revisions, when a patient is coming to you with torn ACL, a graft, you have to think about something extra. And as I said, the wheel concept gives a bigger support on the side. And the concept, again, I'd like to contradict what Dr. Raju said, is not new. That's where the ACL reconstruction started, or surgeries for correcting ACL tear started. It was started with lateral support alone, where intra-articular supports could not be given. So we have started doing intra-articular, and we are getting good results, but then there are certain lacunae, like 5 to 10% of the patients who have something extra which leads them to bigger failures. So which can be probably prevented by that giving support. And the problems of LET is due to bad techniques, like too much of external rotation and fixing. It'll tighten the lateral side, lateral arthritis, but then it should act just like a seat belt. So you keep it anatomical, it should not be stressed unless an extra movement happens in the knee, and the LET works best in my thought process.
So you use it for all soft tissue graft? No.
Absolutely no,
So
absolutely
what
no.
are the what is the percentage of LET?
LETs, maybe 5%. In all revisions, my LET percentage would be 70%, but then in primaries, it would be like hyperlax, obese, or a high-end athlete or a female.
Question for Raju sir. Now this discussion on the LET, it has gone over multiple meta-analyses, systematic reviews, consensus, and then we have this clarity given. So why are we again reconsidering and going back to the basics? Can't we accept it and move on with the indications given? Because it's not like the synthetic graft. It's something already. I thought that the dust had settled on that point.
So it's a non-anatomic procedure. I hope you accept at least that.
Yeah.
So when you want to do a non-anatomic procedure, it has to have a conclusive evidence. So are you seeing an epidemic of ACL failures? I mean, we were doing a transtibial medial portal anatomic ACLs. The incidence of failure, at least in my practice, is not greater than a single-digit percentage. And these are, it's like your trauma surgeon, after putting a tibial nail, he decides to put an external fixator also, so that I don't want a nail breakage. So ACL failures in very active people, if a very active person were to come to me, I would do a BTB graft. One of the most robust grafts known to us, with a ready-made bone tendon interface, and I would probably not add an LET. I would be very wary of doing anything non-anatomic.
But even in the athletes, the re-rupture rates significantly come down from say 9-10% to 3%, 4%.
So it's 9% of what? Of the 33,000 patients published in the Norwegian registry, only 2% failed at 2 years. Only 4% failed at 5 years. So when you look at 9%, you have to analyze 9% of what? In a let's say if you do 100 or maybe 1,000 ACL reconstruction, maybe 1 or 2, maybe the patients who actually fail. Now, the number needed to treat is another concept. So, in order to prevent that 1 or 2 patients failure, you are going to add a non-anatomic procedure to all the other patients. That's something which doesn't appeal to me. But yes, this was just a debate against the LEAP consensus where they gave a blanket recommendation to do a LEAP in all patients 25 years or younger who are active, which is something which should be taken with a lot of salt.
Okay, let's take like we have got a, yes sir, please.
Strangely enough, this is one procedure where you do not document its absence. You don't document it by any imaging and you still do it. I don't see any other procedure in orthopedics where you do not document it radiographically and you still do it. All the studies for LEAP have been on hamstring tendon graft. There are no studies on BTB. And strangely enough, if you read the editorial in all the journals, even the Journal of Arthroscopy where the LEAP's consensus statement is there, no editorial has categorically said that it is to be done. They say it is still controversial, still to be decided. Though there may be a consensus LEAP statement or whatever it is, no editorial has given this.
It was a consensus statement,
and
I think.
A number of different procedures all producing a restraint on the lateral side work. So it just cannot happen that everything works on the lateral side.
So like now patient with pivot shift grade 3, how many of you will do LET or LEAP? Please raise your hand. Okay, and how many of you will do just PTB and leave it alone?
So the data, whether addition of an LEAP procedure to a quad tendon or a BTB, we should have that data by 2028 end when we will publish the Stability 2 trial in which we've taken the BTB graft and the quad tendon graft as well.
So that will give more clear to this thought of whether, so for before and after LEAP study, sir, Sachin sir, so what is your, how many cases of ACL reconstructions when you use a soft tissue graft you add your LET? Every?
Not every case, because probably for each case that requires a more robust fixation, I would not use a soft tissue graft in the first place. So typically I think my practice is around 30% quad, 40% BTB and 30% hamstring as of now. Again, it depends upon what patient population you're treating, you know. So if it's someone who's a housewife or someone who's 40 years old, obviously you use a soft tissue graft. But someone who is younger, less than 25, wants to play contact sport, my go-to graft is a quad tendon graft or a BTB graft there.
So Dr. Sachin, I'll just, I'm just giving you real insights from my practice where I see patients done LET by others.
Yes.
Housewives are being subjected to LETs,
so,
and that is the consensus. I mean, the word consensus is taken by our younger colleagues as gospel truth.
Yes.
And that is something which I'm seeing, and a lot of people with a lot of, I think, tightly done LETs on the lateral side, they say that we are far better off with a torn ACL than after an ACL surgery.
Absolutely true. I mean, if you go to European practice centers, you'll find that in Europe, each and every hamstring has to have an LET. Otherwise, people are too scared of litigation. You know, they know that if you add an LET, your graft rupture rate will go down, which is why in Europe, you'll see that the incidence of LET is pretty high. And that's also a very important aspect. Any more questions here? Let's quickly take one QRS. So, ARS, sorry. Yeah. Okay. So, very quickly amongst all of you, let's have this one ARS up. So, your preferred graft choice for a contact sports athlete is A hamstring, BTB, peroneus or quad tendon. So, contact sports. Okay. Okay, let's see the answer. Okay, so for contact sports, most of you would prefer, or 50% would prefer a BTB graft. Let's look at the next one now, and I think that will tell us what the trends are. So next question, in my practice, my preferred graft choice for a non-contact middle-aged person requiring a primary ACL reconstruction is choice number 1, hamstrings, 2 BTB, 3 peroneus, 4 quad tendon. And absolutely without any surprise, you'll find that most of you would want to do a hamstrings graft. So all of you do believe that the choice of graft varies from person to person. Let's look at the next one. The incidence of adding a leap procedure in your practices. 1, I don't believe in adding a leap. That is Raju, so we'll get 1% vote there. Less than 5%. Let's say 3 to 4%, sorry, 5 to 15%. More than 15%, and I always add. So again, I think there's some bias in this question because it depends upon what patient population you're treating. And if you look at the data, most of us would be doing a leap procedure in less than 5% of our patients. Next question, when you're doing a revision ACL, you will always perform a leap, option 1, never perform a leap, and depends upon case to case. So a revision is probably one of the main indications which was proposed for a leap procedure. So let's see what the data shows us here. So within this August audience, it's a 50-50 split, but only 6% Raju feel that, they will never perform a leap. No, just joking. Last question. Which technique of leap do you prefer? A modified Lemaire, choice number 1. A modified Ellison, choice number 2. A Macintosh procedure, choice number 3. Or an ALL reconstruction, choice number 4. So modified Lemaire is the most popular, followed by the modified Ellison and the ALL. The problem with the Macintosh is that it tends to over-constrain since you're shifting the insertion point on the femur more proximally. So where's Vikram Maskar gone? Is he still here or he's ran away? Vikram? He's left? He's after OrthoTV. Okay, he's after all. Anybody here, anybody else in this hall doing the Jewel procedure? I have started. You have started?
Sir, I have done 4 cases. Sir.
You have done. So if you're doing a Jewel, I want to ask you, sorry? Huh? Hybrid. So you'll add a soft tissue with the Jewel. Sheetal? Standalone. Okay, so if you had to do a Jewel procedure, a synthetic graft, in someone who has a Latchman along with a pivot, will you add an LET? Will you use the remainder of the graft to do an LET? What is your take?
I will not use synthetic graft in such cases.
So,
for such cases, I will either prefer anybody who is doing a pivot, either I will do a BTB, or if patient is a middle age, I will do either a hamstring along with a lateral extra-articular. For me, any patient who is doing a pivot, I will not use a synthetic graft as of now.
Why is that?
This basically I am using just for isolated ACL without any rotational instability.
Okay, but we heard Vikram saying that he will use it in someone who had a badminton player.
Why would an isolated ACL without instability? Nobody complains of sagittal instability. People come to you with rotational instability.
No, so Raju, this is one different point. You will not get grade 3 pivot in all your ACL. So these are selected patient in which there is a chronic.
So grading of pivot is very subjective. What is grade 3 to you?
Yes, so that is what we are looking into. Still, we do not have an objective assessment to quantify how much is the pivot. So this is more of a subjective thing. You grade it as a 1, 2, and 3. And what we are talking about lip procedure or LET is only for the grade 3 pivot. I don't think so. Even the consensus grade 1 or grade 2, they do LETs.
Krunal, you have a point to make? What is your point?
I have a different question. What is your take for peroneus graft? We didn't discuss much.
Peroneus graft. Now you're opening a Pandora's box here.
Yes.
Now. Okay, so how many in the hall are doing peroneus as their choice for a primary ACL? Let's say about 10%. No one here? Okay, so why don't you tell us why peroneus is your first choice?
I believe predictability. With hamstring, I am not very sure all the times I'll get 8.5, but with peroneus, I know that 99% of the times I'll get a graft which is thick, predictable. So that is why.
But we can have the gracilis, if you
so don't. Then it is harvesting 2 tendons.
Okay,
so quadriceps option also there, I think. Especially in athletic population, I don't prefer using this peroneus longus graft.
So it's a question. So we didn't discuss, so I thought that we should discuss.
I think we should discuss this. So what is your argument for not using a peroneus? Raju.
So I think if you see, sir, peroneus longus tendon is a very important tendon which is important for toe off of your gait cycle. Especially in a sports person who needs jumping and sphincter, I think we should not use it, because definitely some amount of weakness will be there in toe off. So I think that is the only reason. It is not my primary graft of choice.
So my indication for peroneus is mostly revision and obese female patient in whom we are suspecting that they won't get a thing, but mostly revision is things.
Raju?
I used to use peroneus in multi-ligament injuries. Now with the synthetic graft, I've shifted to that. I've never been very comfortable with peroneus. Honestly, subtracting such a big tendon from the foot has always worried me, regardless of what the literature publishes.
Sujit?
To me, peroneus is a very easy graft to harvest. I use it only for revision scenarios. When you have such beautiful grafts in the knee itself, like the quadriceps, without any graft size morbidity as such, you can take it through a 2 centimeter incision. Why would you violate another joint?
Do you harvest a split tendon peroneus, or you take the full thickness peroneus?
Full thickness.
Full thickness. Sheetal, what is your take on peroneus? Full thickness or?
Yeah, it's a full thickness peroneus, particularly for what Sarthak was telling, a middle-aged obese female. I think even if you take a semitine gracilis, sometime in a population where a middle-aged obese female is a short-heighted, despite of that, it's very difficult to achieve the diameter of 8, despite of using semiti quadruple in gracilis. Even that semiti gracilis, the length of gracilis is very less, and even the semiti is hardly around 23 to 24. So using a single tendon peroneus for such particular population, I think it's a good choice. And ankle function we have been doing from last 6-7 years, and ankle function it doesn't affect, particularly for that age group and that population. It doesn't, that population only.
They have that graph morbidity side, sir, harvest morbidity side, but that is also going now. We don't see it anymore anywhere.
So there is a paper published, 2,500 cases, a long-term study, and it says that after 1.5 years, there is no difference in function with the other ankle. So this is literature which is published.
No, I have no complaint with the ankle mobility. It's just the graft choice I mentioned.
Sir, any takes on all inside ACLs with shorter tunnels?
So if you have to, if you want to harvest only one tendon and you want to optimize or compromise on the length of your tendon, a short ACL reconstruction is absolutely viable. The methods you can achieve that is you need to use a suspensory fixation on both sides. All inside is just a technique. You can drill a through and through tunnel, and even that will help you achieve exactly the same function. So,
so can I know what exactly?
So that in that case, you are getting a thicker graft with using a lesser tissue.
No, you will use one tendon. So instead of using a 3+2 hamstring, you will use a single hamstring, make it 4-fold. Correct? So that you can get about 15 millimeters into both sides, which is viable. Previously, we did not advocate that because we did not have very good suspensory fixation devices. With the advent of good fixation devices, I think this becomes a very logical method, because then you can optimize how you're using your grafts in case you want to add, you want to reconstruct, let's say you want to augment the MCL along with your ACL, and you don't want to go to another graft choice. You can basically optimize that, and that can be extremely useful. So short tendon grafts with about 15 to 20 millimeters in the socket, absolutely viable choice. And it all depends, because you have very good fixation devices.
Sachin, I think it's a very clever way of folding the ACL. A quadrupled ACL on a button device will be less diameter than a all inside prepared graft. That's mainly because of less overlap of collagen fibers in the quadrupled construct and a greater overlap of fibers. So that's a simple mathematical thing. So the same graft folded 4 times can give 2 different diameters.
Okay, thank you very much for this fantastic panel. I'm really excited because we have a tremendous guest amongst us. It's our great pleasure to please welcome Padma Shri, Padma Bhushan, Padma Vibhushan, Dr. Nageshwar Reddy sir. A big round of applause. May I kindly call upon Professor Ashok Rajgopal, our founder president, to please escort this very famous and very important person who has revolutionized the way we look at patients and healthcare on the dais. Thank you, sir. Thank you.
PPT. So good evening, everybody. This is a proud and a prestigious moment we have been waiting for. And it is really a historical moment that this SKI meeting has a motivational speaker in the form of Nageshwar Reddy sir. Let us first welcome him with a big, big round of applause. He needs no formal introduction, but I think it is my duty to introduce him very briefly. He is the chairman and chief of gastroenterology at the AIG group of hospitals. He is the one who's founded it. The current flagship hospital, which is his brainchild, is 850-bedded hospital at Gachibowli. Another one is 300 beds at the Banjara Hills, and the 150 beds, the older one, at the Somaji Guda. I have had the privilege to visit Nageshwar Reddy sir in his flagship hospital at Gachibowli, and what they say is, seeing is believing. I went there about 2 months ago, and I was flabbergasted to see what was going on there. In a nutshell, he sees totally about 4,000 patients in one day. He does 750 endoscopy procedures in one day. And I was amazed to see those endoscopy suites and how the patients were registering. And if somebody has used AI to the optimal level, it's none other than Dr. Nageshwar Reddy, because with his vision, he has enabled the registration systems. He has enabled for people to pick up the red flags where there may be waiting time has gone up more than 30-40 minutes. The height, weight, the primary of the patient, the basic data is captured by sisters in literally 30 seconds, 1 minute, and the doctors have it. So, in short, what he has created there is fantastic. He has shown us what AI is, and he has something called as a Mira, where, he has used, if you're just talking, dictating history, it will capture everything. It will put it in a small kind of a note. There are questions you can ask to this AI person and you will be answered. I can go on and on about this, but I think if some of you want to see what healthcare can do and what is the pinnacle of healthcare, then you've got to visit Nageshwar Reddy sir's hospital in Gachibowli. That is something which is phenomenal. His commitment to innovation and patient-centric care has made him one of the most respected medical pioneers of our time. Dr. Nageshwar Reddy's brilliance lies not only in his clinical expertise, but in his ability to inspire, elevate, and build institutions that shape the future of medicine. Single-handedly, he has transformed AIG into a global benchmark for excellence in healthcare, and for this, he has been given the 5 ASG Crystal Awards, which is a very prestigious award given by the American Society of Gastroenterologists and Endoscopists, which is the only award outside America for any person to receive, and Dr. Nageshwar Reddy has received that award. It's really very, very, very commendable. At the same time, he has also received the John Hopkins Captain's Chair Award. Dr. Sabyasachi from John Hopkins is here. And nobody else has received this award outside the US except Dr. Nageshwar Reddy. He is also the inventor of Nagi stent, which has really revolutionized the treatment of gastroenterology, and it is indeed a very, very useful innovation. He's amongst the few handful of doctors or few people in India who have received the Padma Shri, the Padma Bhushan, and the Padma Vibhushan. All 3 awards received by Dr. Nageshwar Reddy. I think I should not introduce more and more because we have short time and he has a flight to catch. He's going to get a flight at 8:50 where he has to travel. So sir, we are honored to welcome you and we wish to felicitate you with the Puneri Peshwai Pagdi, which we have got all the way from Pune for you. With Dr. Sachin, if you can give the Pagdi. The shawl first. Rajgopal sir, you can give the Pagdi. Dr. Ashok Shyam, please come up.
May I kindly request a standing ovation for Professor Nageshwar Reddy, sir.
So friends, today we are very excited to hear this talk and you will ask what is the connection between orthopedics and knee surgery and gastroenterology. Today after this talk, you will realize, what is entrepreneurship, how doctors can be entrepreneurs and how should doctors approach it so as to become the best in the field. And for this, may I invite Dr. Nageshwar Reddy sir to please enlighten us on his talk. Doctors and entrepreneurship. Over to Nageshwar Reddy sir.
Thank you, Parag. Thank you very much for that very kind introduction. In fact, Parag said that I must give the oration the cap on, but my head would have become very heavy. I don't want it to. So Parag actually told me, can you talk on something to make the doctors very successful? The orthopedic meeting is there, can you make? So I said, how many minutes? He said, you have about 15 minutes to do this, to make all of you very successful here. So I'll start with this question, what is success? Success is power, success is fame, success is money. So how many of you, let's start by finding how many of you are successful here. How many of you have a lot of money? I thought Ashok Rajgopal, no? Only one, okay. How many of you have fame? Again, a lot of you are very famous. At least few hands. No? And how many of you are very popular in your... Everybody is popular, nobody is raising hands, they are all shy. So at least let us assume that 10-20% of you are very successful in terms of money, fame, popularity and so on. But still 80% of doctors are not, so I'll change it a little. Success now has been redefined completely. Success means the meaning of success in all sociological magazines or journals are, success means being happy with what you're doing. So how many of you are happy with what you're doing now? See, Parag, 3 minutes I converted everybody into successful doctors. So I think our concepts are so different. My talk is going to be very brief today on doctor and entrepreneurship. In fact, the term entrepreneurship is a term that I didn't know till recently. To give you a little background, I'm a gastroenterologist. I did my gastroenterology at PGI Chandigarh, DM. I did a little training in Germany on advanced endoscopy and came back. I started practice here and over a period of few years built up these 3 large institutions, I think Parag already told you. So people started labeling me as entrepreneur. I didn't actually know the meaning of entrepreneur. So when I went back to ChatGPT to check what is an entrepreneur. An entrepreneur is a person who initiates, organizes, operates a business venture, taking on greater than normal financial risks in order to do so. The ultimate goal is achieving financial success, realizing personal business, or addressing a social need. So I thought maybe I may fit into this, and I think all of you look at this definition and see how many of you could actually fit into this. So my journey has been starting as a small practitioner in gastroenterology in a just two rooms, one for consultation, one for doing endoscopy in 1984. Then I had a long story, but I don't want to go into this. A lot of luck, serendipity and so on helped me to make the first 200-bedded hospital, old hospital, Somajigoda. Subsequently, we made the large, the present Gachibowli hospital of 850 to 900 beds, and then came the Banjara hospital, which we recently opened, 300 beds. So I call this an accidental entrepreneurship because I didn't realize all the values of entrepreneurship when I started this. What happens is many of us, we finish medical school, go into individual practices, go into group practices, then sometimes build a small nursing home in our towns, join corporate hospitals. Very, very few of us actually go into building institutions. I think Professor Sancheti, Parag's father, was one of the few ones who did it very early on. And incidentally, he was also probably at that time the only doctor who got all the 3 Padma Awards. Yeah. So ultimately we come to, so why not? Why isn't everybody doing this? Why isn't everybody building institutions? Why do you just build a small nursing home? Why do you join a corporate hospital, give all your skills to develop, and that hospital develops, but you are only a part of that hospital? Why not you're doing? The reason is this. The reason is we have, as doctors, when we pass out of medical college, we have what is called the middle class mentality, which is very different from entrepreneur mentality, very important. Middle class mentality means wealth. Doctor, you want to go, you want to do practice, make money for your family, invest into lands, invest into real estate, make more money. And this is a middle class mentality of wealth. When entrepreneur mentality, which many leading entrepreneurs now have, many of them are engineers and so on, startups and so on, they have what is called a valuation mentality. So they don't create wealth, they create a value. And value is much bigger than wealth, because value is not only creating a wealth for yourself, but wealth for people surrounding you. Like Infosys is created by Mr. Narayan Murthy. He became very rich, but he not only became rich, but he created a value so that everybody around him became rich. And also it created a value in the society. So we are all bogged down as doctors by this middle class mentality. We have to get out of this and think of an entrepreneurial mentality. That's the most important thing. The reason why we don't also is because we are not taught how to do this in our medical college. Medical college only teaches you skills. You can become an excellent physician, excellent surgeon, excellent orthopedic surgeon, become the top guy in knee, hip, or whatever part of the thing you're operating. That's what it teaches us, man. But it never teaches us how to be an entrepreneur. It never teaches us how to manage people. Doctors are the poorest at managing people, and never teaches how to manage money. Because money is a bad word because we are all supposed to be helping poor patients. So if you make money, it's bad. If you don't have money, it's bad. So we don't know how to manage money at all. So these are the 3 important defects that come, and that's what happened to me. When I came out of PGI Chandigarh, I was coming from a very low socioeconomic class. My father was a professor of pathology, never made any money. We never had. So I came out with about 5,000 rupees. That's all, I just had that. And then started my journey. The first few years, I was doing very heavy practice, endoscopy, and made a lot of money. And then about 5 years into this practice, when I thought good amount of money, my father called me home and after lunch told me, son, you're a big failure in life. I said, failure? I went to the best college, graduated, I got a big practice now, and you're saying it's a failure? He said, yes, you're a failure because have you built any institutions? Have you taught any students? Have you published any research work? Have you looked after downtrodden? None of it was there, zero. So in his thinking, this was the success, and my success of just making a lot of money in practice was a failure. That day I decided that I'll change my course. Now, that's when I started thinking like an entrepreneur, but there were a lot of other interesting incidents which helped me build these institutions. I can't go into because of lack of time, but for you who are sitting here, the most important questions that you think about is two. Why should you as a doctor, why should you as a great orthopedic surgeon, very skilled person, very successful in life, why should you think of being an entrepreneur? That is the first question. And second, if you think of being an entrepreneur, how should you do it? As I said, I didn't know anything about it. Most of my knowledge is diffusion. When I look back, these are the important factors. I thought I should convey these to you. Why? Because we don't realize this, but doctors actually make the best leaders. So, but what is happening now, all of us are joining corporate hospitals and these hospitals, and they are run by individuals who make us work. They are leading us. In terms, if you think of the intellect, in terms of what they can do to society, they are much below us. But these corporates are leading us because they have taken over. They know the business of medicine. They are entrepreneurs. And we should not be left behind. We should run our places. Doctors themselves should be the ones who are running all these things. And that is the reason why we should start thinking as entrepreneurs and not as just workers in these hospitals. The other thing is, however good you are at your job, however great you are, a point comes when you develop a burnout syndrome. A burnout syndrome is one, you're working very hard, you do very well, but you get fatigued, you have a sense of loss of sense of identity and so on. There's several definitions. So very successful doctors, many of them, after a certain period of time, develop a burnout syndrome. And the only way to avoid it is to be an entrepreneur. And when you're an entrepreneur, you never develop a burnout syndrome. This is an important point. So next, we'll come to how. How do you become an entrepreneur? The three important shifts. Again, this was my journey. I learned it retrospectively. Leadership, team building, and managing. These three things you must know. If you know this, then you can conquer. You can become a great entrepreneur. Let's start with leadership. Leadership is a very tightrope walking. It's a very narrow pathway. Again, I learned it over a period of time. In leadership, you realize that you have to be strict with the employees, but sometimes you have to be very soft. So it is oxymoron, many of these. You have to be dismissive. A lot of employees come, talk to you, try to, again, I think Parag should have having considerable experience in this. They'll come and tell you all sorts of things. And sometimes you have to be appreciative when they have done things. Appreciation is very important. Sometimes you have to be disconnected. If you go on listening to all the things that they say, you get so involved that you do micromanagement, that's not good. But again, there are occasions where you have to be empathetic. Somebody has lost their loved ones. Among your employees, empathy is very important. The three most unused phrases that I found, which I learned are very important in leadership is, first to say thank you when you have something is being done. Second is apologize, and sometimes apologizing in public to somebody whom you by mistake scolded, did something, makes a huge impact on the whole group itself. They know that you are empathetic, and when you apologize, that makes something. And the most important thing I've learned is, whatever decisions we do in a hospital, I always ask the doctors around me and so on, what do you think? Okay, we want to start this new department, what do you think? This what do you think becomes very important because you get a wide opinion. Even now, all of you in your practices, in your nursing homes, some of you may be running bigger institutions. When you do something, if you ask your colleagues, what do you think? Should we do this? It makes a huge impact. Not only do they respect you, but also you get very good opinions on this, very diverse opinions. So this is something that... The other thing, I was actually the president of the World Endoscopy Organization for 4 years. It involved 150 countries. I was very immature. I didn't know how to lead at that time. And one of the occasions, there was a French doctor who made a mistake. I just shouted at him. And the secretary, who was just a lady, secretary of that organization, called me and said, "Doctor, this is not the way how you do it." She told me the way how to very effectively shout or scold at people is the sandwich technique. And that I found extremely... What is sandwich technique? You want to shout at somebody, you call him to your room, not in front of him, call him to your room. First praise him, or saying you're doing a good job and so on. First 2 minutes, just praise him. And the next 30 minutes, you shout, you scold him, do everything. And afterwards, as he's going off, you tell him, okay, you're doing a good job, keep it up. So this is called the sandwich. When you do the sandwich technique, the opposite person doesn't realize you scolded him. It comes to him very slowly. He doesn't feel very abusive at you, and it's a very effective way of dealing with people. And this is, I found, extremely useful. The second important thing is communication. There's, in fact, the different, again, as we get trained as doctors, many of us get very skilled, we become good doctors and so on. The difference between a good doctor and a great doctor, the difference between a good doctor and great doctor is skills of communication. Now, Mr. Senior Sancheti became a great doctor because not only the skills of doing procedures, but because of the skill of communication. And we all think that communication is just talking well to all the... Communication is talking 25%, listening 75%. We must have, as leaders, the patience to listen to what people say, absorb everything. And if you look at all the great leaders, even all our prime ministers, chief minister, all of them have gone to that stage. They listen very well. Listening is a very important part of communication, and we don't realize the importance. So this is another important component. So this is what Angela Duckworth, who's written this very famous book on power of passion, says that talent and effort makes a good skill, but if you want to, from a good doctor, become a great entrepreneur, a great doctor, you have to have the skill of communication. You have to have the skill of communication of telling the investors, look, this is the best place for you to invest, of telling your friends, this is the best place for you to come in, of listening to what they say as counters and then starting to reply to them. So this is how, what differentiates all of us are good doctors, but to become a good entrepreneur, you must have skills of communication. And skills of communication is something you can easily develop. The second aspect of entrepreneurship is team building. Again, this is something we are not taught officially. Team building requires certain effort, and this is, again, a very important component of building institution. In fact, I was having dinner once with Mr. Narayan Murthy, who founded the Infosys, and I asked him, so whenever I meet very important people, one question I always ask them, what is the reason for your success? So I asked Mr. Narayan Murthy, can you give me in one sentence, what is the reason for your success? And he said, I don't want a sentence, I just want one word, and the word team. Word is team. So the reason for success for him and reason for success for many of us who are going to build institution is teams. Teams are the ones which make us. So Henry Ford very famously said, coming together is the beginning, to keeping together is the progress, and working together is success. And I think the only way we can be successful, small group of doctors, big hospitals, bigger group of doctors, is by team. Individually, we cannot do anything together. Because if you have, what happens is, in your college, for example, or in your school, you would have found many people who have been at various stages in life, you know. There are people who make things happen, there are people who watch things happen, and there are people who wonder what happened. So you should not be left behind as somebody who wonders what happened. You should not be somebody who makes things happen. You must not watch things, you must make things happen. So this is very famously said that real success comes to the doers, not the observers. We observe what such person successful, he did this and all. You can go on observing, but that doesn't make you successful. Only the doers become really successful. So we, again, in our group, we have several people in the teams, and we know who's a winner, who's a loser. Winner has a solution for every problem. The loser has a problem for every solution. You know, you ask some, what shall we do for this? They'll give some excuses. No, we cannot do this. Is there government regulations, this regulations and all. But a winner doesn't think of all that. He says, this is the solution, let's do it. So this is very, very important. So surround yourself with positive people. If you want to be a great entrepreneur, surround yourself with positive people. Take out the negativity. If you have negative people around you, they drag you down. It's the positive people who will drive everything. The negative people, either you convert them into positive people or they go out of your group. This is very, very important. Positivity is something that radiates around the room, that creates an atmosphere where everybody succeeds. Negativity pulls everybody down. So very, very important again. So I was once in this very famous group of entrepreneurs in Hyderabad. They called me as a medical person. They were industrialists. They were very famous startup companies and so on. Mr. Ramcharan is a leader of, he's a Harvard professor who will teach you how to do management. I couldn't afford to go to his courses because they're very expensive. They charge a couple of lakhs. But fortunately, this time when he came, the Harvard invited some of us to interact with him. And when you interact with him, he asked one question to all the people, all the successful industrialists there. How do you recruit people into your team? Because they're all very, everybody was successful entrepreneur. And everybody is saying, I'll take this brilliant guy, I'll take this chap who's done a lot of work in this area, put them together. So when he came to me, I told him, I'll take a very average person as part of my team. He was very surprised. What do you mean average? I had to tell him that in medicine, you don't require brilliant people, you require average people. But you require people who are passion, and are a team person. So I think when you recruit your people for the team, 3 things you must see. Are they compassionate? Are they passionate about their job, that they don't leave everything at 5 o'clock and go back to their family because they have to, but they have the passion to continue? Are they part of the team person? If you take somebody who is brilliant but not a team person, it will destroy the whole institution. So what I figured was the best people for you to build up your teams are average people, compassionate people, passion, and team persons. I think this is a very important formula that we should keep in our mind before we build teams. So this is the reason why, to a large extent, we have succeeded, mainly because of the team. All the publications and all that is because of the team. Individually, it's impossible to do these things. And this is very important to emphasize. So I'm running this large hospital. I think Dr. Guru Reddy also is here. He also used to run a very large place. So people ask me, how do you do all the clinical work? You're running this. So the formula that I developed is that I'm still very passionate about clinical. I don't want to leave my clinical work. If I had a choice between doing good clinical work versus not running a hospital, I'll do good clinical work. So I've now made a formula where 70% of my time I'm in clinical work, seeing patients, doing procedures. 20% we have a large research wing, research and academic wing, which in fact we have 2 Nobel Prize winners as part of a faculty who come to visiting, Barry Marshall, who discovered Helicobacter, and Maria Lucina, who discovered the genetic knockout mice. So they're part of a faculty, so they come, we have a lot of discussions. So 20% of my time, along with our research group, I spend, and only 10% of the time I spend administration. The trick here is to delegate your administration to a group of people who can do it, because they're all not doctors. There are like chief operating officer, chief financial, they're all people who are trained to be doing this administration. The most important thing for us as doctors when you're doing this is to get the right group of administrators whom you can just give everything, and you spend just maybe half an hour or 1 hour every day on that aspect. They look after everything. So this is again an important trick. If you try to do administration yourself full time, then it goes nowhere. And then you have to be willing to sacrifice your clinical part for doing this. And I know, seeing all of you, that you wouldn't want to do it. For you, clinical is still the most important. But to be successful, you can do this very easily. So one of the things that's not often used in medical or even in entrepreneurship. Intrapreneurship is what you do in your hospital. Entrepreneurship is what you do from outside. Now, entrepreneurship is keep testing your people, your administrators. You give them a problem, see how it is solved, see which administrator is better, and then start delegating work. So this entrepreneurship is also very important. Constantly, however big or small your institution is, you have to constantly keep practicing this entrepreneurship. So the last important part is managing money. This is something I was very bad at, but you have to learn. To be a good entrepreneur, you have to learn managing a lot of money or managing no money. If you don't have money, what to do? This is very important. So I think this, I often quote what Richard Branson said, that we went into business not to make money, but if you have fun, the money will come. It's exactly the same with doctors. We don't practice to make money. I think this is universal. We practice because we have passion, you want to cure the patient, you enjoy doing it. Money comes secondary. It comes as part of that. It flows. This is something that we have to keep emphasizing all the time. Because one of the things is, if you want to big hospitals or big corporate hospitals, it's not so easy. All of us don't have that kind of money. The easiest way, of course, is to get a rich father-in-law. But I think for some of us, it's too late also now. So we have to depend on either taking loans from the bank or getting private equity people. This is the most crucial question. The private equity people, I never knew anything about it till later on. I was fortunate that we didn't get bad. The private equity people are divided into the good, the bad, the ugly, the ugly, the ugly. Most of them are ugly, because what they want to do, all these private equity want to invest in a very successful hospital. They'll buy it up, slowly see that the doctor has less and less and less percentage of his coming, and slowly dominate the doctor to that extent that we have examples in India of big founders of big hospitals who have been thrown out of their own hospital because the private equity guy comes. Their bottom line is graphs to see how every month your percentage of income is increasing. They don't care about anything else. So it is extremely important when you select. That is one. The second thing is, as far as possible, we think bank loans are bad, but bad private equity is worse. So as far as possible, limit your private equity involvement to less than 30%. Whatever happens, if they're more than 50%, you are finished. That is not a good institution. Try and limit it to less than 30%, definitely not more than 50%, because then you get so diluted that you don't have any say in what is happening. The reason is, of course, Guru will recognize this person, but most others will. What again happens is, we try to do our own financial juggling, doing this and that. And we are very bad at it. As doctors, we don't have the skills, we don't have the long-term vision. We are extremely bad. I found only about 10% of doctors who are really good at financial issues. So what I would suggest is, if you're thinking of building institutions, get a good economic advisor. Mostly the safest people are your own relatives. If your brother or brother-in-law or so on, good at finances, take them. They are the best people. If you don't have that kind of thing, at least take a person who's going to be extremely reliable, is going to advise you. Most of the downfalls of doctors who have started enterprises is because they've had economic advisors who are doomed, who are actually the reason for their downfall. So I think this is, again, extremely important. So you have to know certain words. In fact, when I started AIG, the equity people came in, luckily good people. They asked me, what is the EBITDA, what is the ARPO? I never knew any of these words, all foreign words to me. What are all these? EBITDA is earnings before tax, depreciation and amortization. So ARPOB is revenue per occupied bed, and ALOS is average length of stay. These are important. I never even know. The reason they're very important is the value of your hospital or whatever you create is based on the EBITDA. The EBITDA into 20 is average for hospital. So if you're making 20 crores EBITDA, earnings before tax every year, the value of our institution is 400, 20 into 20. Multiply into 20. That is for the hospitals. For different industries, they have different landmarks. So this is how valuation is done based on EBITDA. So you can make huge profits and you can make huge turnovers in the hospital, but if the hospital is making only 50 lakhs per month as a profit, as EBITDA, then your valuation is 50 lakhs into 20, only 10 crores. So that's the thing. So everything depends upon your EBITDA. So that's the reason why now people don't want to build big institutions, spend a lot of money on that. They rent a place, run a very successful enterprise. Then you show a high amount of EBITDA, evaluation goes up. So this is one of the tricks. Now the other thing is, I didn't realize this, that there's an inverse relationship between ARPOB and ALOS. If your average length of stay in the hospital is low, then your revenue per occupied bed is high. This is a very important principle that the American hospitals have created now. The average length of stay in an American hospital is 2 days. Average length of stay, even in the best corporate hospitals in India, is 4 days. Many of them, when we started, it used to be 6 days. We try and cut it down to 5 days. So cutting down that is extremely important, and we don't realize the importance of this ALOS. The second thing is, we don't know when you're running what should be the cost, how much loan you should take, what is the repayment that you should do, and all these things. Again, there are a lot of calculations on this, but I'll just come to the salary part. What we realize when running hospital is that for a hospital to be successful, your average salary to doctors should be less than 18%. Rest of the shop less than 18%. So your average salary burden should be less than 36% to be successful. If it is more than 36%, I've seen many hospitals going to 45%, then you won't be successful. Because for the hospital to get a value, you have to limit your salary burden to less than 36%. There are things called receivables. You think the hospital is doing very well, but you have a lot of institution patients who don't pay the money. If your receivables go to more than 1 month of what you're making profit, then you won't be able to function. So similarly, it's all a lot of how much loan you can take for replacement, repayment. All these things comes from financial knowledge. But just to say that when you're running this, the operations, you think that hospital very busy doing well. No. Hospital profit comes only 10% from operations. Your theaters, you may be doing 10 surgeries a day, but that is not getting it. The profits come from your diagnostic division, 60%, and pharma, 50%. That's where your profits come from. So what you should do is, when you're running large institutions, you put very strong people in your pharma area so that no pilferage is occurring. Put very strong people managing the diagnostic area, because diagnostics has a lot of pilferage can occur, overbuying can occur. There can be nexus between people who supply all the kits and the people working in the hospital. So all these issues are there. So concentrate on that. Don't worry about operations. You don't lose money on operations. That is there. Again, as you go along, these are the 3 very important attitudes that are there: humility, positivity, and networking. I'll show you one very interesting study that came, which was done by Raj Shetty, published in the Quarterly Journal of Economics in US, where he showed that he looked at all the big achievers in life after a certain period of time, and found that those who achieved big in life, when you went back to the school and saw how they were, they found that those big achievers had 3 important things: discipline, determination, attitude. Attitude means networking. Those who are disciplined, those who are determined, and those who are networked are the ones who became extremely successful at the end of the day. And what determines how if you look at, again, different people, there are 4 different types. First says, I want to be successful, I won't do anything about it. You can't just sit down and be successful, you have to do something about it. The second, most people are this, including non-doctors also. Average life, average goals, average outcomes, they're happy in life. The other ones who fail and got depressed, but those who dream big, who are the ones who finally make it in life. And then, so what you must do is that all of you should have a realistic ambition that today, okay, you are doing your surgeries, you are very successful, but tomorrow you can't become a Professor Sancheti. There is some difference. It has to go stepwise. Also, you should take reasonable risks. Don't take huge risks because you are responsible for your families, you are responsible for people around you. So if you take huge risks, if it doesn't come out, so take reasonable risks so that something happens, you can still bounce back and come. And important that failure is never final. You can get blocked by the toll, but there are side roads around it you can come. This is very important. So this is a very, very important study that was published a few years back. There's a book called Troublesome Inheritance, which actually classify people into different, some may be good at college, bad at college, average, 3 groups of people. This is natural genetics in all of us. Who does well, who doesn't well depends on something which is most people, average people continue like this, but good people, you can see that some of your students in the college very good, but they don't do well in life. Some who are not good, average, do very well in life. What actually determines is the attitude they get 5 years after they pass out of the college. 5 years after medical college you pass out, your attitude is what determines how successful you are. Attitude meaning social determination, discipline, and networking, these 3 things. So what happens immediately after the college, and this is very good studies which have shown this, these books I'm just quoting for you to read. So I'll just like to say success is not an accident, it's the result of an attitude. If you think you can, you can. If you think you cannot, you cannot. Either way, you're right. But it's only the positive people who get the results. So as a doctor and entrepreneur, it's important to have this important concept. This is Daniel Kahneman who got the Nobel Prize for economics. He said there are 2 types of thinking, the fast thinking and the slow thinking, and this is a very good book on that. As a doctor, you must all have fast thinking, instinct thinking. You're opening, there's arterial bleed, you have to go and catch it, stop the bleed, and so on. But as an entrepreneur, as somebody who's running down, you must have slow thinking. You must rationalize, think, is this decision right? Is this decision wrong? Discuss with people and come to. So totally different approaches. And we have to integrate both this to become well-known. It's often said, can you still be a good human being and also be successful in business? These are 2 examples. They are 2 very good human beings, but they've been very successful in life. So, in fact, being a good human being is also good business. People start saying, okay, this is a good group of people. So we'll go and see them as doctors, The other important thing is whatever you do in life, you have to enjoy because nobody can do hard work. Hard work is the most impossible thing. So what we have to do is smart work. Convert your hard work into smart work, and that you do by enjoying work. For example, I'm a gastroenterologist. Whole day I'm doing endoscopies. I convert this into an enjoyment. I'm seeing something else in the screen. Every patient has a story. Every patient's got an interesting lesion. So convert it into smart work. When you're operating, for example, keep gossiping with your nursing staff, gossiping with the doctors around you. Make it fun. No? That's the way you can go. The other important thing is this Rajat Gupta, a very famous McKinsey president, when he visited us once, he asked, I asked him again, same question, how did you become so important? So he said, a very important thing to me, he said, whenever you reach your comfort zone, raise the bar, set the bar higher. You may be practicing, reach comfort zone, making a lot of money, set up a nursing home. Maybe doing well in nursing home, go higher bar, set up an institution. So each time you set a higher bar, you do better. This is very important. And also be friends with your colleague. This is something, again, medicine doesn't teach us. This is my colleague GB Rao, 1997, 2025. We are still together. Only our hairstyles have changed a little, but otherwise we are. So this is also very important. So what we have done by creating this institution that Parag showed you, we created a valuation. So the institute, the doctors, everybody gets valued. We create a patient-centric and academic institute, and of course society benefits. We still have a long road. I'm now setting my bar a little higher. We're going into other cities and so on and expanding our own place. Many of these I've achieved because of luck, serendipity. I can't go into the story because some interesting stories are there sometime later. But I think it's important to realize that great things are not done by impulse, but by a series of small things coming together. Small things happen in your life. You have to grab these chances, and then once you grab this chance, then of course the final result. This is a very good book that I'll recommend you to read called The Fluke. How in our whole life there are a lot of flukes occurring. Only when you recognize this fluke, grab this opportunity, then you get the final results. So all of us have to set smart goals, specific, measurable, achievable, realistic, time-bound. And these smart goals are very important. Just don't make very aimless goals. So I'll do next this thing, I'll do. No, next 3 months I'll do this. Next 3 months, next 3 years I'll do this. So for me, formula finally for building responsible institutes are serendipity and luck, very important. Converting your hard work into smart luck. team and communicating well with the team. These factors will determine. We run courses now with ISB on entrepreneurship. If some of you are interested, every year, twice a year, we do this course where doctors are taught about all this entrepreneurship in more detailed fashion, especially the financial aspects and so on. And I think, as I said, it's the team that's responsible. It's the power of subconscious mind thinking that we have to do this, we have to. All that we are a result of what we are taught. You keep thinking very positively and everybody can achieve what they finally want. And finally, let me end with this. I compare this like a glass ball, rubber. Rubber ball is like your work. You throw it down, it bounces back. You can lose it, it comes back. But glass ball is family, friends, and health. Once it drops down, it breaks, it never comes back. So look after this very carefully. Look after your family, friends, and health, because this is something you can't bounce back again. So, ladies and gentlemen, thank you very much for your kind attention. Just a few thoughts on what I thought.
I think this was a fantastic oration, sir. Means in 20-25 minutes, you've just shown us the gist, and that is why Dr. Nageshwar Reddy is Nageshwar Reddy. A big round of applause for sir. And on his behalf, I invite you to visit his hospital. Sir, I hope I can take that liberty.
Thank you, Parag. Thank you very much.
Thank you very much. He has a flight to catch, so we'll not take any questions. Please have a seat, everybody, because he has a 8:50 flight to Pune, actually, the city where I come from and Sachin comes from. Thank you, sir. Thank you very much.
Thank you so much, dear friends, for staying with us. And it was absolutely a huge eye-opener. And thank you, Professor Nageshwar Reddy, for this fantastic oration and completely very motivational for all of us. A couple of housekeeping notes. Our dinner will start in the lawn, which is adjoining shortly right now. That's the first point. The second is tomorrow morning we have breakfast with the masters or meet the masters. So in the breakfast room, we'll have 8 tables which are set up. And that starts at 7:30 in the morning. We have key leaders like Dr. Ashok Rajgopal, Dr. Savya is there, Dinshaw is there, all of us very important people amongst us, and we can have any academic, non-academic discussion with all of them. And of course, our sessions will start dot on time at 8:50 in the morning. So thank you for a very sort of intriguing and engrossing and engaging day one. Let's all join for dinner, and we'll see you in the morning as well. Thank you.